Good afternoon, everyone. This is a perfect session right after lunch and after this vibrant discussion we just had across different topics here. So the topic for this session is Voices from the Front Lines, 4 Pillars of Community Health. And we have 4 amazing leaders here from different community organizations that I've had the pleasure of meeting with recently. And I'm Kavitha Gnanasambandan. I'm the co-founder and chief commercial officer at Blooming Health. I'm originally from New York, but I'm close to accepting Cleveland as my second home. And last night, I got a really lovely tour of downtown Cleveland from Tone herself. So I've seen all your stadiums. I need to come to the game one day. But I think I want to start off with an observation that Tone helped me have yesterday. I was going to quote a lot of numbers initially, but I think the story will resonate better. So as we were driving to downtown Cleveland, Tone took me through this neighborhood called, I think, Glenville, Cleveland, Glenville. Yes, I got it. So Glenville, Cleveland, and I think I saw her high school as well. But I think a very important observation we made there was the bridge that separated one part of Glenville from the other part of the neighborhood, which is more affordable and more, looked very different. The disparities were very obvious when we were driving through from one part of that neighborhood to the other part through the bridge. So the disparities is what we are all talking about here. How do we bridge them literally? And also, how do we work together to address them across these 4 different pillars, from food insecurity to aging, to housing, to primary care and community-based primary care, through coming together as a community care hub to address them together in the communities. So in Cleveland, especially, this is in Northeast Ohio, there's around 2 million people across the Cleveland in the Northeast Ohio. But then in terms of the disparities that we see here, we've talked a lot about infant mortality, but then also around lead poisoning and different types of issues in housing and aging. But all these issues are very deeply connected. It's the same individual. When somebody is impacted by food, they're also impacted by housing. They also have an older adult that they're caring for and might be aging. And they might have a chronic disease and they need to go get blood pressure tested or other types of healthcare needs that they have. It's the same individual that's being served across these different organizations, but we often see only one side of their story in each of these circumstances. So how do we come together? And there's a lot of different people and programs and hopes here to tackle these challenges. But imagine if that resident in need could instantly connect with the right service provider at the right time, with the right clinic or the community group, without anybody falling through the cracks. That's the imagination and the vision we want to build towards, that somebody gets the help they need at the right time from the right organization. And that's what I want to build this conversation towards, is you guys are already doing this at some level, but what are the different opportunities that we need to think about, even with these changing circumstances, to get there? So I want to start off by introducing this amazing panel. And I want to ask each of you to introduce yourself, your organization, but then also give one example of a recent collaboration where you worked with another organization in a way that measurably improved the community health outcomes. So I want to start off with you, Jess, if you can introduce yourselves and the Greater Cleveland Food Bank.
Well, good afternoon. My name is Jess Morgan. I serve as the Chief Programs Officer at the Greater Cleveland Food Bank. Thanks for inviting me to be a part of today. I would say that, we heard a little bit about our Community Resource Center model from Tiff as she was kind of reporting out on our table. I wanted to expand upon that just for a minute. The goal of that center is really to impact a person's food security. There's a lot of research out there that suggests that somebody is food insecure because they are struggling in areas of housing, healthcare, employment, and financial literacy. And so our model is really designed to not only provide access to really healthy foods whenever somebody might need that, to take that barrier away, but bring in service providers, because I'm telling you, the food bank's not going to become a health clinic. I'm not pricking anybody's finger, right, to take a blood sample for diabetes check, because there's really amazing organizations out there that do a lot of this work already. So we brought these organizations together to collaborate with us so that when somebody comes in for food, which is the key, which is what brings people out to the center to begin with, they can also connect to one of 16 other amazing social service providers under one roof. It takes away that transportation barrier. It takes away sometimes a communication barrier between organizations trying to help the same person, and really gives that individual a sense of respect, dignity, and hopefully hope moving forward. So that is the, I think, one great example of collaboration that we've been working on the last 2 years.
Awesome. I want to go to you, Orion, if you can give us an overview about Benjamin Rose.
Thank you so much. I'm Orion Bell. I'm the CEO at Benjamin Rose here in Cleveland. And our mission is to be a trusted partner on the aging journey for older adults and the people who care about them. And one great example of a collaboration that we have in our community is some of our family caregiver support programming. And we're fortunate that we're able to place some of our care navigators in the hospital systems. So if you're at the geriatrics clinic at the Cleveland Clinic, if you're at the HIV clinic at Metro Health, and some other examples where our care navigator is there, is introduced, it's a live connection, it's a live introduction, a live handoff to that person that's part of the hospital staff, part of the team there. So when there's a conversation about discharge planning or care at home or conversations for a loved one who's dealing with the diagnosis that their loved one just heard, that dialogue can be there and begin in that setting. And we know from lots of experience in these programs over the years that helps reduce the stress for the patient as well as for the caregiver. It increases the health outcomes for both of them.
Yeah.
And creates a much better environment for people to address the health needs of their loved ones and themselves as they continue that journey as a family and as a group of support. So that's just a great example of something with folks in the room here today.
Absolutely. No, I was very impressed by the co-location of the staff at the clinic. I think that makes a lot of sense to address the needs as they arise. Robert, I want to go to you to introduce Better Health Partnership and the amazing work you're doing.
Sure. Hi, everyone. Nice to see people again after the morning session. So they kept me for another session. So good to see you all. I'm Robert Eick. I'm the president and CEO of Better Health Partnership. Really thankful to be here. I was sitting up here thinking how this afternoon I stepped away to check email, and I had email exchanges from folks from each of the organizations up here that my team has passed along to me. And it's funny that like we know each other and we're doing very similar work, and still there are barriers, right? So it was an interesting kind of epiphany to me, and I think we know a lot of the barriers, and now we want to find solutions. But just one example of working with an organization where we've seen some interesting, meaningful output recently was actually with one of the managed care entities for Medicaid, and we were on a call, and a number was stated that for our Pathways Hub model at Better Health Partnership with community health workers, really helping close key gaps in social need and medical service gaps. They highlighted that of the 1,700 patients that had been cared for in the last year in that model, 10% of them had only had contact with someone in our hub, but no PCP contact and no contact with health plan care management during that time. And they had not been able to engage them. And so just being able to think like that with a partner who, sometimes payer relationships are strained, but in this scenario, it was not strained. It was actually a collaborative environment to say, hey, let's do a pilot for that 10%. And let's look at some type of a value-based model that might be built around that to ensure better connectivity with primary care, with social service needs being met, et cetera. And I think that was a very encouraging example, because for every one of those instances, you have other instances where you want to bang your head against the wall because nothing's moving. So that was really encouraging to experience that. Thank you.
Awesome. Well, thank you for the work you do to bring people together. Domonic, Hopson, we want to go to you to talk about your work at the Neighborhood Family Practice. Yeah.
Good afternoon, Domonic Hopson. I'm the president and CEO at Neighborhood Family Practice. We are a community health center, a federally qualified health center, tasked with providing comprehensive care to 22,000 patients each year. And we provide primary care, women's health, behavioral health, podiatry, pharmacy services, and HIV care, among a number of other things, with our primary goal of help trying to solve or address some of the health disparities that we are all too familiar with across Cleveland. And for the example I'll give, I'll go to our partners at the Greater Cleveland Food Bank and our Food is Medicine program. And so we have a program where our patients that are diabetics or that have a hypertensive diagnosis can get referred by one of our doctors or nurse practitioners to go and pick up food out of our Food is Medicine program, where we have a collaboration and partnership where food is delivered to our team each week. And there's a dietitian that staffs that Food is Medicine program. And so when the patients come in, they get education on how does these individual foods impact your specific diagnosis, and then how do you prepare or cook them. And I think that's especially important for many of our patients, or a significant portion of our patients that are former refugees or newcomers to our community. So some of these foods they've never seen before. So you can imagine getting something that you've never seen or cooked. What are you going to do as soon as you get out of somebody's line of sight? You're likely going to throw it away. So our team is educating them on why this food is good, why it's important for them to have it. And what we found is that they then bring our team members dishes back. So when they come for their next pickup the following week, they'll bring a dish that they've made and say, hey, thank you for giving me this. This is the recipe that I found based on my country's origin or the ingredients that we use, and I would love for you to try some. And so it's just been special to see that program grow, and it's been operating over a year now, and it's continuing expanding, and we're looking to now add new team members to that area, because it's been hard to keep up with the growing demand. But what we know is that so many of our patients are dealing with many of our social drivers of health, including food insecurity. And so for us, trying to just solve a little bit of that, right? There's so many other disorders that we're hoping to expand to, but starting with those two, we've seen a significant impact, and also seeing those patients be more controlled. Because one of the things that we found is that it really comes down to the number of touch points that you have with some of our patients. So you may be coming in to pick up food, but we may also check your blood pressure or your A1C while you're there. And then if it's uncontrolled, then we'll get you connected to our provider or a clinical pharmacist that may be able to adjust your dose on the spot, as opposed to we may not see you for 3 or 4 months. That's just not enough touch points to make sure that we're controlling some of our patients' conditions that have a lot of different challenges that they're facing. So looking forward to having this conversation.
Awesome. Well, thank you everybody for the amazing work you all do. We've been interacting with all of you in multiple ways. I want to start with a point that Doug made this morning, which is like all of you have been addressing social drivers of health for a long time. I think Ben Rose has been around for hundreds of years, and many of you have been around for even longer as well. So social drivers of health, while it's a terminology that I think is helping us all realize the importance of this, you've been a very resilient organizations that have been delivering the services for a long time. So I want to start off with a hard topic first and get it out of the way. I think we all know the elephant in the room on the funding challenges. And this started not just with HR1, but with the COVID pandemic unwinding of the Medicaid aspects as well. And you've been dealing with that over the last 2 years. And with all of you all, it's kind of like running a marathon while the ground is shifting under you. So I want to start off with that question on like, how are you dealing and approaching that in the current circumstances? Somebody already talked about the fact during the discussion that the problems are not going away. We are still going to continue to tackle them. But if you can start to talk about how you're thinking about this, I think diversification of funding sources or other means in which you're trying to make sure you continue to meet the demands and the needs that are arising in the community. So I want to start off with you, Orion. I know we talked about this yesterday around the anxiety and the lack of reliability in federal funding, which is affecting cash flow for many of these organizations. So I'm curious to understand, how are you thinking about approaching and tackling these?
So somebody was asking me the other day about how the impact of all the changes and the proposed changes have on our organization. And I said, well, fortunately, our immediate impact seems fairly minimal. But what it has done is it's made all the social workers' jobs harder, because changes in eligibility screening and going from once a year to twice a year, or other kinds of changes in that space, or lowering the upper age or raising the upper age limit for someone to qualify for a program from 55 to 64, makes some of that work harder for people. And a process that was difficult before is even more complicated after. So just making sure, one, that people have accurate information, because a lot of what they, hear in the neighborhood or see on the news is wrong.
Yeah.
And making sure that they know what the rules really are,
Yeah.
and helping navigate to that, I think has been really important for us. And the thing I've just have to tell yourself too is that very often the aging population is not the intended target of those changes, but that's because the people making the rule didn't talk to the older adult that's affected by it, and helping people understand that if you change a eligibility document or change a determination or change the way people verify a proof of address or other kind of information, that for an older adult whose birth certificate is a mimeographed copy of something that was printed in 1941,
Yeah.
or who hasn't had an active driver's license in several years, or moved from their apartment into an assisted living facility, and getting the documentation for proof that that's where they really are now can be challenging for someone in a way that you might not initially think of. And so that's one of the ways that we try to address some of that with folks is let's just, let's try to help you follow the rule.
Yeah.
And also let's try to educate people about how a rule changes affects those folks that may not have been top of mind when you made the change.
Absolutely. No, it's a big behavior change. It's kind of like, again, flying the plane and building it at the same time, because you yourself are learning the rules and you want to make sure people are understanding the rules so they can stay on the benefits. So I know, Jessica, when we were talking about the panel, like SNAP benefits was a top focus for you. So how are you making sure? I know one of the things about SNAP benefits is making sure that the person who's food insecure today doesn't stay food insecure. So that's one of your solutions for that. So how are you thinking about helping those folks? Yeah.
Sure. So there were some pretty significant changes to the SNAP program when the reconciliation bill passed in July. Two of those largest changes are the work requirements, as Orion mentioned. Older adults who are able-bodied now between the ages of 56 and 64 will have to work at least 20 hours a week in order to receive SNAP benefits that they qualify for. That is new, and that will impact, I think, all of us up here in some capacity. And then the state cost sharing of the program itself, which we really won't see the impact or effect of until 2027 or 2028. There's a lot of speculation and numbers out there that I'm not going to share today, but we know that we will see an increased need as it results or relates rather to individuals no longer having access to SNAP benefits or seeing a reduction in SNAP benefits. There's a couple of concerns there, of course. One is there are 200 food banks across the country, and collectively last year, those 200 food banks provided about 6 billion, with a B, meals to people in need. The proposed cuts to SNAP equal about 6 billion meals lost. So when we think about food banks and our role in trying to make up for those reductions, we simply cannot do that overnight. So that, of course, is a huge concern of ours. And then also the burden of these changes to social service organizations, primarily those organizations that are responsible for approving the benefits and doing the determinations and having the interviews with the people who are applying. I'm talking about our county jobs and family service offices and how they will be impacted. We already know that our partners at the county are understaffed. And so with these additional requirements, it's certainly going to have a trickle down impact. So some things that we're doing to try and at least be as planful as we possibly can, which seems a little impossible, but we have to do something, is we're really scenario planning. We're doing a strategic plan that will launch in our next fiscal year, but we're also scenario planning and thinking about the what ifs and what we need to do if XYZ happens. But one of the things that our president and CEO said recently in a meeting was that we have a responsibility as it relates to food to be a steady stream of support for our community. And so we're really going to be focused on that. We've certainly seen some reductions in food programs, specifically at the federal and the state level as well. So we'll really be relying on strong community support and also working really closely with our public elected officials and educating them and ensuring that they understand the impact of these changes. and what they will have on our neighbors in need.
Absolutely. And I think I want to hear from Robert as well on the role of healthcare in all of this too, because we need to capitalize the system in a way that we can cross-pull funding from multiple sources when one source goes down.
Sure, yeah, and thanks. And I think, for Better Health Partnership, most of our skills and assets and positive things actually sit outside of us as an organization. We're pretty small. So we just hired our 11th staff member. But the work that we're able to get done is pretty great, largely because of folks up here, folks that are here, and we hope to just be some type of a glue or scaffolding or co-design facilitator of certain things that really have had some inertia to move forward, right? So for us, to a large degree, any barriers that any of our partners or collaborators are having, those are going to be things that we're going to feel and want to be a part of. And so for us, that means throughout some of this time, the opportunity we have actually increases because the need is growing pretty drastically, right? So I think that's true across our health system partners, across FQHCs, BH providers, those focusing on older populations, those thinking about specific disparities that are focused around things like lead, et cetera. So I think in terms of how we think about it, we have two sides of the house, right? We have a Pathways Hub model that really is a capitalized model to have insurance companies pay for these community health worker-led services, just like they would an office visit, because we know if we say that 80% of health is social, then why do we put all the money on the healthcare side and none into the social? So how do we fix that wrong pocket problem in a way that's not just grant funded, but sustainable? I think that's exciting. It's kind of a little bit ideologic, and it's fun to work in that way because it feels like subversive and good. And I think the other part of what we think about is how are we doing capacity building of that network of community-based organizations that we get to work with? And we're very fortunate to knowing that one of those entities has 20 health workers and is a large health system in Cleveland, and the other one has maybe just hired their first CHW ever. And those are very different operational models, very different revenue potential things, et cetera. But really, those are both equally, or maybe even the smaller one, more important in some ways to the community health and so forth. So I think during this time, what we're seeing is the human imperative of this in terms of what we're seeing is hard. And that's like the primary thing that seems to hit us with what we're seeing, the patients that Domonic and his team are seeing and others. But also from an operational standpoint and opportunity standpoint, I think that's looking different across our partners, right? Some people are seeing things contract in this one area, but expand elsewhere in terms of opportunity. And that's very much the case for us to think about. We know that Medicaid, folks who receive Medicaid benefits have massive social need often, with 40% have 3 or more unmet social needs. But that same thing is true for Medicare, and it's, 20% or so have that same amount there, and same with commercial, right? So there's this a little bit of a misperception that unmet social need really is an uninsured and Medicaid problem. We know it's certainly something we see in Medicare and even in commercial insurance, with a good number of folks having at least 1 or 2 unmet social needs. So how do we, as a Pathways Hub that is meant to help address that in a hyper-local, person-centered way, diversify the types of contracts we have with payers to be Medicare Advantage, to be commercial, to be dually eligible contracts, et cetera. So those are some of the things that we're thinking about kind of during this time, and ways that we want to bolster revenue so we can keep serving our partners. So.
Absolutely. Well, thank you so much for that. And Domonic, I think it comes back to, as the HR1 impact is looked upon, a lot of it is going to come down to increase in uninsured population. And as you rightly said, a lot of refugee population is being served in your communities. How are you thinking about continuing to support them? But then also, there is a lot of responsibility here in the communities, in the health systems and others as well, because to Robert's point, 80% of the drivers are outside the hospital walls, but only less than 10%, not even 20% is being invested there. So if the impact continues, there's going to be more ED burden, for example, a lot of triaging happening in ED. So I see a lot of overlap or a need for collaboration between FQHCs and health systems, but I'm curious to hear your thoughts on the solutions here.
Yeah, I think the one point I try to always communicate to people is whenever someone loses their insurance coverage, they still continue to be our patient. Just because your insurance changes doesn't mean that you're no longer a patient of our organization. And so for us, the difference between someone on Medicaid and being uninsured is a 97% drop in revenue for every visit. And so when you start to multiply that by a few hundred or a few thousand patients across 2 or 3 visits a year, it's a big number that as an organization, it's hard to account for that. And so one of the things that you mentioned is for us is trying to lean into diversifying our revenue streams and doing so with things that both help our bottom line with revenue, but also impact our patients. And that's why we've leaned heavily into our pharmacy program, for example. And we're in a process of opening our 3rd pharmacy within the next couple of weeks, and then we'll open our 4th one next year. And that's critical because many of our communities have lost so many pharmacies, right? Rite Aid bankrupt and closed all of their locations. CVS and Walgreens are closing hundreds of locations across the country. And so for our communities that for so long, that is the one healthcare provider that they knew they can access. They can go and get information from their pharmacist at the retail pharmacy. They've lost that. And so for us, being able to bring a resource like that back to our community and do it in a way that both helps our organization, but also provides connected and coordinated care for our patients. Because our pharmacists, our clinical pharmacists, they have access to our health record. They have a direct line to our providers, so they can coordinate care and make sure to give that feedback to make sure that the care team members are actually working together and collaborating the way that healthcare was created and the way that it should be. So that's one of the things that we're solving for. And I would say the other thing that I don't think many people are talking about is the unfunded burden that falls on our social service organizations. So Jess rightfully pointed out our partners at Job and Family Services and our state and county partners that will be doing these additional eligibility checks. And they're going to be doing all of the job verifications, the school verifications. But for us, we have to ask ourselves, should we be investing in additional financial assistance employees to help our patients navigate that system? Because again, that's a 97% drop in revenue for us. But we also know that when patients lose their health insurance, they typically withdraw from our healthcare system, and then they end up in an ED, which doesn't help anyone. So it's in our vested interest, just from a community perspective, but also from a revenue perspective, to invest in more resources to help patients maintain their coverage, but there's no dollars coming to help us do that, right? And so not only are we losing revenue, but we're having to add employees, hopefully to help our patients maintain their coverage. And I don't think enough people are talking about that.
Absolutely. And I think I started with the funding question mainly, again, because it's total cost of care for one individual that's happening across multiple segments, right? So you've gotten that out of the way. It's a major one, the funding aspect. But then the second aspect is operational efficiency and the infrastructure for continuing to do this at the same cost while your revenue is decreasing and the demand is increasing. So as I mentioned, if it's the same individual that's going to multiple organizations, coordination is critical. And coordination, even within medical arena, is tough, but then medical to social is even more challenging. It's a beautiful idea, but in the reality, there's a lot of messiness in terms of platforms, workflows, systems, and data. Well, it's a very broad topic, but I want to start off with you again, Dominic, in terms of like how, let's talk specifically about the social care referrals you're making to these partners here. How are you doing them today? And I know you mentioned you're juggling multiple referral platforms. And what is the impact of those? If you could streamline those, what would it look like? And what are the current challenges you're having?
Yeah, it's tough. And it's one of the biggest complaints of our workforce. We were so happy that our partners at University Hospital, when they came online with Epic, and now most of our local federally qualified health centers and all of our hospital systems are all on Epic. And so now we're able to talk through our systems and refer patients back and forth and see how our patients are doing in a more intentional way. But when it comes to our social partners that are not on a health record, we're using platforms like Unite Ohio. And we are new to the hub with having now, I think, 5 or 6 community health workers that we have in our organization. So we're using and bouncing between now 3 different platforms that I know of. And I'm sure there's a couple more that our team members are doing because they're having to go on the Ohio State site to make sure that people have insurance. And so that's a burden. I don't care how many screens you have, when you have to be in 5 or 6 different systems, you start to not want to do it. And then you have to double document, copy and paste in multiple systems, which is a major barrier. But I would say these systems that we have are an improvement, because now I can see that maybe Metro Health or University Hospital already put a referral in for that patient, and I can see what happened with it. Did they go to that referral? Whereas historically, they go to Metro or to NFP, and then we're both putting in the same referral, not knowing that the other person is already working on that.
Yeah.
And it's a lot of waste in our system. So there is improvement there, but I think that next step is going to be improved in integration of these different platforms and softwares, and hopefully continue to work to get on the same foundation of a system that allows them to talk to each other and allows for us to see how our partners are doing, and make sure that this system is working in an effective way when it comes to, are the partners getting what they need from us? Are our patients happy with the referral or the partners that we're referring them to? And then is it truly impacting overall health, which is the reason that we put the referral in the first place?
Absolutely. That's 100% aligned with Blooming Health's mission as well, in making sure that member experience is accounted for in all of this. So I want to come back to you, Jessica, in that regards, on like, you are on the other end. You're receiving the referrals from healthcare. And we've talked a bit about this, like on the level of triaging your team needs to do before they can act on a referral. So if you can talk a bit about the operational challenges you face and what's your ideal solution.
Sure. So I think all of us up here will say that one of our operational challenges is having enough staff to do the work. That will always be a challenge in the nonprofit world. I've never heard of a nonprofit being fully 100% satisfied with the amount of staff they're able to have. We have one staff member who accepts thousands of referrals from healthcare partners a month. She is incredible. She might even be listening. Sometimes it's really hard. We have a policy that we will try, is when referrals come in, we will try and connect with that individual 3 times. So we'll call them once. If they don't answer, call them again. If they don't answer, the 3rd time, that will be it. Sometimes the data is not as accurate as we would like for it to be. I think that there's one example where we called a household to do some follow-up, and the patient was a 3-year-old. Well, 3-year-old, right? That's not, can't help that. So data accuracy, I think, is really important. But I think that goes back to Dominic's point, which is, when you're in multiple different systems, trying to then filter information from multiple systems into another system that's going external, there's challenges with that. We're all humans, and humans make mistakes and errors, and that's okay. So I think that is a challenge. I think one of the things that, my background is in social work, and so much of this work, we also want to find out what the impact is for our various services and the referrals that are going back and forth and that follow-up. And we don't have a really great way to do that. And I do believe that technology can help us. What happens after, Neighborhood Family Practice or Metro Health or UH refers an individual to the food bank because they screen positive for food insecurity, and we make contact with them. And we refer them we fill out a SNAP application for them, and we submit that. And then we give them 3 food pantries in their neighborhood that they can go to. And then we never hear from them again. We don't know, because we don't have the staff, or we don't have a good process to do that level of follow-up. And so if we really want to figure out, is all of this service coordination working, we have to be able to track that impact. And sometimes that's a lot harder than it is in concept. So, but I do believe that technology can be helpful there. I just don't know what yet.
No,
So.
I hear you, Jess. Like a lot of CBOs and nonprofits we speak to your point, half or like 95% or more of your time is invested in just doing the work. Like if I can find the staff, if I can find the time to do the work, that's 95 or 105% of my time. So measuring the impact while everybody has the heart to do it, it always comes, unfortunately, at the lower rung of things and priorities I need to get to. So that's why we want to develop AI agents that can be all assistants to all of us in supporting at least some of the routine tasks that can be automated. But I want to go to you, Orion, in terms of the operational gap, especially. I know you are all very focused on evaluations and data collection as well, and you're involved in operations day to day. So how do you see any of the challenges you all face when you work with other organizations in terms of coordinating care or in terms of tracking data?
So I think one of the ways that we experience that with our clientele is this idea of service coordination. So service coordination is this unfunded activity that all nonprofits are involved in, right? So for us, a lot of times that might be somebody that attends one of our Rose Center locations, which, you know, social and recreational activities and a hot lunch during the day and different classes. Or somebody who is a resident at Margaret Wagner Senior Apartments, and there's a social worker there that interacts with them. There's a social worker that interacts with our folks that are on a home meal delivery route with our Meals on Wheels programs that has an intersection. And all of those three examples, those are people that are probably not plugged into the public systems as intensively as somebody who is maybe on a Medicaid waiver and is a client of Western Reserve, right? So that one touch point they have, because they live in my subsidized building, or they're on a meal route, or they do a chair aerobics class, that is their point of contact to that system. And so finding ways to make those connections with folks in that environment who often do not present with that issue, right? They didn't come in that day to tell me that they're food insecure. They came in for the aerobics class. And finding the ways that you can identify that, that is respectful of the person. You know, that's not the conversation you're going to have with the instructor in front of the other 10 people in the room. But finding ways to do that in ways that are respectful, ways that you can limit the number of times somebody has to tell their story over and over, because we do that to each other too. And ways to streamline some of that process and help people have accurate information and relay accurate information, the 3-year-old, right? To help streamline some of that process for people. It's difficult enough anyway. It's hard to be poor in the US. And a lot of the systems are designed to make it difficult to access a benefit or a service that was designed to help you in that circumstance. And so ways that we can reduce those barriers, pull some of those things down, those collaborative effort. There's a lot of residual benefit just from the fact that we have a staff person who's in Jessica's building, right? So they're there in the lobby, talking to folks, talking across the table to the other agencies that are present, and oh, I didn't know you did that. Those kind of conversations that happen. And that's a part of that too. That's just part of the synergy of those programming coming together. If the technology supports that and facilitates that, it makes all those things easier, it makes them better, and also makes them easier to track and to count, to follow up on.
Absolutely. Yeah, we were talking to Lisa Weissman yesterday and mentioned that you guys are developing these comprehensive assessments, as you just mentioned. When you encounter this one person, you're doing this more comprehensive assessment. To your point, if you can make that assessment information available to everybody, that becomes that story that they don't have to retell 100 times to each one of them. So absolutely agree. Like, the information you have is so rich, and if we can help you share that.
I always tell people that nobody has one problem, right? There's always multiple things going on. And just being open to how you can have that conversation or how you can address that for somebody.
Absolutely. Well, thank you for sharing that. Robert, coming to you on how do you see the role of technology in reducing the silos to some extent between different organizations? And I think we've talked about efficiency as a key part. It's not just a function of technology, of course, it's process design and technology design, and how you implement technology within the workflows. So how are you seeing the opportunities there?
Sure. Yeah. And not to speak for every single community-based organization in the room, but my sense from talking to folks is everyone wants and needs to find efficiencies. And it's either because we are worried that we can keep the lights on or not in 3 months, or because this moment seems poignant and tangibly important to maximize opportunity ahead of what might be worse things, right? So I think there's maybe one of two reasons why efficiencies are key for probably everybody here. I think from my perspective, it's really thankfully the latter of like the growth opportunity for BHP in a couple areas is really tangible. However, we're really kneecapped by inefficiencies in systems and processes. Everyone, if you talk to anybody on the ground, it's like double documentation is like a 4-letter word, right? That's a real issue. And I say that when someone's thinking about joining the hub, like here's the good, the bad, and the ugly. Part of the ugly is system inefficiencies, double documentation. Jenny Pate knows those things maybe better than anybody. So these are things that are troublesome, and manual entry, and not only manual entry, but then redundant manual entry when it's double documentation, right? So those are things that I think hurt our efficiencies, but also staff well-being. Like they are being used way, way, way below their skill set to do something you could actually probably have like a well-trained 10-year-old do, and that, which is terrible. Like why do we have to have staff doing something that's not fulfilling in that way? So that's the other part of it, is just like retention, not only growth of organization, but retention of staff and happiness is a key thing. I think the other part of this is I think we're all in this space because we want the community to be healthier, and we want to be a part of partnering to do that. And part of the need there is around data and evidence generation for return on investment. And some of us probably hate that term. I might be one of those, but also we kind of need to think that way with payers or other partners, right? So to be a part of that, we need to actually think holistically about not only data sharing acutely for like an ADT feed to trigger that someone's been in the ED and we want to wrap around extra services, but also long-term, how are we coalescing data to show ROI in terms of analysis to have proof points with payers or other partners. So I think that's the other area of like breaking down silos, not just clinical operations wise, but also proving our reason for being and why there should actually be more dollars flowing into the social service side than there currently are. Finally, you made a comment, I think, about Jessica's, like about referrals and which directions referrals are going. And that kind of struck me. I'm thinking about this, like really our approach, I think everyone's approach probably is there's no wrong door for a social referral, right? So like anything you could name of a pathway, I would hope that we would find a way to enable that happening. And it could be the most obscure thing you could imagine. Like, I don't know, the garbage collector notices someone doesn't have food and then they somehow refer something, like that type of a thing, if possible, would be perfect. So I think we try to have a no wrong door approach. But similar to an earlier conversation, we hear things where some payers are capping the number of social service referrals per time frame. And that cap might be 2 or 3 within a couple months period. But we know the average person on Medicaid may have 3+ unmet social needs, right? So there's some like intellectual disconnect as well to that, in addition to just the funding position that puts us in, where people are going to need more than one referral often in a short period of time. So those are things, thinking about breaking down silos and also having comprehensive care coordination for these things that require data pieces, trust pieces, contractual arrangements, all those things.
Absolutely. No, I agree. I think I want to underscore the workforce part that you mentioned, because we've interacted with the different staff members and CBOs and others that are supporting the populations. And everybody is in this job, not for money, mostly for purpose and meaning. And you want them to get that satisfaction by supporting the people, not by doing double entry in multiple systems. So how do we help them perform at their capacity, at their best, in terms of what they are interested in doing versus mundane tasks that could be done differently?
And just to say, I think the idea of scaling for us, as I said, is very tangible. But the amount that we could scale by staffing up, even if it were a responsible fiscal environment to staff up big, would just be a drop in the bucket compared to what we could actually scale if we had much more efficient systems and processes. Like I would, if I had to pick one absolutely or another, I would say efficient systems and processes versus hiring 5 more people. Like that's an easy choice for me. And I think those might be about equal in terms of productivity increase, depending on how the efficiencies would go. So
I think that segues well into my last question. If you had no restraints in terms of money, policy, or other issues, what would be that one solution that can make these systems more efficient, right? Like, so you can do what you want to do best and not have to spend time in coordination that's inefficient, but then also in ways that the money can be maximized to serve the people. So if there's one change you would like to make tomorrow to improve the coordination across these different pillars and organizations, what's that one thing you would do?
I'll try. I think each of our organizations sitting up here and in the room have different needs based on the types of services that they're providing. And I have found that sometimes when working with systems who great step forwards, it's hard, they're not always customizable. They're
Yeah.
not always customizable to the needs of the specific organization, while also serving the needs to another organization. So I think, you know, for me, it would be doing both of those things, you know, having customizable systems for your own organization that also can be customized to others and help us all meet the same goal.
That's great. Yes. Orion, do you want to take a stab? Just dream. Think beyond your limits.
So, yeah, thank you. The thing I would fix, I think, is the easier part. There are a lot of people that, you know, there's some great programs and great services out there. The challenge for us and for most organizations and for communities like Cleveland is there's a lot of people that need some help. They don't qualify for the public programs.
Mm-hmm.
And so one of the benefits of maybe a more efficient system is a deeper conversation about bending the curve. You know, not just, you know, if you're sick enough and poor enough, we can help you. But to make that conversation be more about how do I keep you from getting that sick and that poor? And that's the one that we need to try to get to. Because these are not just programs for people in poverty. These are concerns that every retiree has. Middle income folks worry about paying their bills. And how do we find ways to address that for folks effectively?
Absolutely. Now, I know in the morning we talked about aging and then maternal health. So it falls on either end, but there's also the in-between, even across ages, that people undergo different challenges, right? So even on the middle ground of across populations, we need solution.
And one of the most vulnerable populations is that 55-year-old who worked at the factory that just closed.
Yeah.
And they're too far away from the public programs for retirees, and they don't qualify for some of the other, those kind of questions come into that too. So I don't know how to be more efficient. That's the engineer's guide, right? But I know what I would do with it if I had the resources. It would be there. That's where we'd focus.
Yeah. Prevent them from getting into the safety net zone. Yeah. That's where you catch early, predict things early. Yeah.
Yeah. So I think thinking through this, for me, one of the biggest, this is a pie in the sky maybe, but I think we all know it's going to take investment from every sector that's aligned and targeted and evidence-based to move these issues, right? So I know Angela and others were up here earlier around infant mortality. I mean, $1 million is not going to fix that. 5 million probably is not going to fix that. I don't know if 10 million fixes that, right? So like what are the things we need to align to move that? And how's that look across corporate philanthropy, private foundations, city, state, county, federal investment? And what's capacity building look like in that? And the money's not just being thrown at a solution that's not considering capacity. So for me, in a scenario where all those things are aligned in terms of even readiness cycles, right? Like Dominic's organization might be ready to do something on a partnership and we're like, give us 6 months, we're not there. 6 months from now, they're not there because they've already either done it or something's changed, right? So the alignment of funding and just readiness seems to be a big gap that we're seeing. There is plenty of money out there that's going into various things. And so it's a matter of like realigning that and maybe putting that in pockets that aren't already heavily lined. So.
Absolutely. And Dominic, you've been in the government too, so you should be able to talk on all sides. What's the ideal solution in here?
For me, the ideal solution is one system.
Yeah.
We talked about, you know, the multiple systems as our employees work in, but I think if you have a system that shows the application for SNAP, that shows the application for Medicaid, that shows the social referral and the healthcare work that we're doing, or at least do it in a truly integrated way that you don't have to jump around. It will help us support our patients and have a better line of sight to all the things that they need in order to be healthy, but also what they need in order to be active members of our society from an employment standpoint. I always try to tell people you can't separate economic mobility from health. I don't care how many jobs you create. I don't care what you do in that phase. If our community isn't healthy, then they're not going to be able to sustain their employment. And so those two are tied together. But for me, I think the one pie in the sky is just one integrated system that we're all working in, but a patient can allow or determine what they want you to see. So there still is that view of some privacy. If you don't want your employer or your healthcare provider to see something over here, you have a way to turning it on. But to be able to support us, and then because we all need so much of the same information. And so when they go to each one of our organizations, they're all filling out one form and we're asking the same thing over and over and over again. So why can't that already be populated because they just left Jess or they just left Orion shop to get support, and now I'm pulling that in and I can get right into helping solve whatever problem that we're trying to focus on that day, as opposed to asking them to go through and fill out that same paperwork that they've done 10 times now.
Absolutely. No, there's a lot of action items in here for technology developers and how we design technology. But then also for the audience here, I want to remind everybody to think about the different solutions that people are dreaming of and wish that they could have. It needs a lot of support from process design, policy design, and how we think about implementing them. And I think I have seen that it is feasible, because in New York State right now in 1115 waiver, it's a pretty bold initiative, but they're investing $4 billion just on social care infrastructure and capacity development. So we just need bold leaders and finding ways where the money is already existing and how do we reallocate it to innovate and achieve these solutions. So I'm going to stop here and provide some time. You can ask questions, that's right. Yes, exactly. So I want to give time for the audience to ask any questions. Yes.
Who had their hand up? I'm sure somebody had their hand up. Didn't I say hand up? What about on Zoom? Any chat people? No chat? I'm gonna call. I need to see the names on chat. Then I can really call. Oh, Nima has a question. You have a question, sir? As he's doing that, I just wanted to share, since you were talking about different revenue opportunities and different ways of looking at things. People probably know Patrick Kennedy. He's now doing a whole mental health initiative, and he is doing it by teaming with a group of investors, private investors. So he's going around the country actually developing mental health solutions with the investor community. So one of the questions we're going to get to is who's missing today. Investor community is one that will be a great addition to add. So Nima, Dr. Nima.
I'm not a real doctor, so especially in this room. Actually, you spoiled my question. So my question was, like, we have different stakeholders on the panel here. By the way, amazing discussion. Thank you so much for that. Who do you think is missing in the room from the discussions today? Who is missing to be able to connect some of these dots together? I feel like there is definitely close-knit relationship between your organizations, but I mean, I don't want to again like necessarily bias your answer, but should health plans be a part of this conversation? Should any other stakeholders to be a part of this?
I'm happy. I mean, so this is maybe a fairly recent learning of mine that whenever we think we've had adequate community involvement in designing or discussing something, we still haven't had adequate community involvement. And so I think for me, that would be probably the most important piece. I've seen that with our lead work, and some of the greatest expertise in the work we're doing with lead is actually from the community of people with lived experience. And that's something that you can't replicate with other participants. So I think that for me is one key group that is really central.
So saying in disability services, nothing about us without us. Yeah. And yeah, that you want to make sure that, you know, you want the payer perspective, but you want the consumer's perspective too.
Government, right? We talk about managed care organizations, but primarily the people who are funding them are federal and state governments. So making sure that they're at the table helping solve some of these problems, because a lot of the frustration, and I'm not dumping on them, but a lot of the frustration is with the systems that people have to navigate or their inability to navigate those systems. So making sure that they're at the table.
I kind of have a question here. As an organization, a small organization, boots on the ground, literally working with these folks. One of our barriers, okay, in addition to just trying to get people connected, is authorizations, okay, to speak on behalf of them or to get information, say, a jobs and family services authorization, okay, to be able to kind of connect, go back and say, okay, did you get, all the documentation I sent in for, Robert? But they won't, you literally have to have them sign. Okay, there's got to be a better way. And on a follow-up to that is with the providers that we're referring to. Okay, did they go to their appointment because, geez, their phone was turned off because they don't have any more minutes or whatever? Because now we're getting into minute phones. If you can even, we're going back that way too, where people cannot get physical phones. They can get SIM cards, but they can't get a physical phone. Okay, everything is more difficult. So how can we leverage technology to loop in the community health workers and the folks that are trying to get these people connected? Because that's a lot of heartburn on us, just trying to, there should be like one form that can say, geez, you can give my information. You can help, this is, I can't help them if I can't get the information. So.
I think there's multiple layers to this, but if you want to answer from an organizational standpoint, we can start. I think from a technology standpoint, definitely that's the goal. I think that we talked to Lisa yesterday about consent. I think even to collect the consent, you need to be very specific about what you're getting consent for and at multiple levels. And it takes a lot of time and effort to collect the consent. And so that's one place technology can easily automate things that are more simple. It doesn't need an informed consent like a clinical trial, but more simple consent like, I'm okay to share my information with other organizations. You're free to send the referral to Greater Cleveland Food Bank, right? So that part can definitely be easily automated with technology through an AI caller that's calling the individual and collecting that information. But the same thing around closing the loop, right? When you send the referral, the other organization, as just mentioned, is spending 100% of their time or more to just deliver the services. So if they have to go into one more system and say, yes, I delivered the service, yes, the case is resolved, that's one more step for that individual who's already overwhelmed. So that's another place, and technology can easily automate it by cross-verifying service units data or by talking to the individual directly. Did you get the help that you needed addressed? And or was it the right referral? Do you need something else? I referred you for food, maybe you needed financial help. So definitely a place where technology can play a role, but from an organization and process standpoint, if you see any opportunities.
Any other thoughts from the panel members?
Probably because we have the same question.
Oh, well, then I'll give a little suggestion. This is my little plug since, everybody knows I love DC so much. If you have not signed up for Health and Human Services CMS website to get notices, I strongly suggest you do. They send out requests for information all the time. There's a big one about transparency with the consumer, a big one about how you make referrals, how to make it easier for exchanges between the healthcare professionals and community-based groups. It's a big priority, particularly for the Innovation Center. So sign up, get that information. When they ask for something, send a letter in. There's nothing as important as responding to requests that come from the federal government. Use your national associations also to be your voice, but don't just assume they understand what's happening, because I can promise you they don't hear and see a lot of the things that you do on a daily basis. So.
Awesome. Thank you, everybody. This was a great panel.
Okay,
thank you so much for all your
you.
conversation.
Excellent. Thank
Yeah.
you, Kavitha.